Hello, friends and fellow colleagues. I am Dr. Parag Dharap from Mumbai, India, a consultant pathologist. At the outset, let me wish all of you a happy, healthy, and prosperous new year, that is 2021. I am presenting today to you performance evaluation of machine learning based infectious screening flags on the HORIBA Medical Yumizen H550 Hematology Analyzer for Vivax Malaria and Dengue fever. This study was performed at Dr. Dharap's Diagnostic Center, Mumbai, India. Now, over centuries, scientists and researchers have been trying to unlock hidden potential of blood cell counting to diagnose, screen, and monitor various diseases as well as general status of a person. With advances in blood cell counting technology, we have not only been able to achieve accuracy and repeatability, but also been able to assess some qualitative attributes of individual cells. Over decades, cytometric methods mentioned in this slide have been used in hematology analyzer to be employed to assess presence of malaria in a given blood sample. Majority of these methods utilized instrument-generated data regarding cell population, cell volumes, and light scatter, followed by mathematical processing of this data to achieve the diagnosis or screening of malaria. Other methodologies have targeted hemazoin pigment production capabilities of malarial parasite or use of fluorescent dyes to detect RNA content with the help of laser technology. Multi-parameter flow cytometric malaria detection has also been known and tried and tested. But there are limitations to these technologies. CPD-based calculation models have shown low sensitivity and specificity. Fluorescent technologies are yet still out of reach as they are mainly present in high-end instruments. There is also inability to serve the high throughput for the need for cost-effective or affordability and easy accessibility in malaria endemic areas. Mosquitoes, although from different species, are common vectors for spread of malaria and dengue. Therefore, both infections are frequently coexistent in endemic regions. For malaria, microscopic diagnosis of malarial parasite in blood is still being considered reference methodology and a gold standard. But again, it is very time consuming as one has to observe thick and thin blood smears. It is labor intensive, and yes, it definitely requires expertise to observe malarial parasite. Analyzer generated results and graphs such as shown over here, a histogram of WBC from 3-part differential and WBC matrix on 5-part differential cell counter do display certain abnormal peaks and abnormal scatter events as indicated by arrows in this particular slide, especially in significant infections by Vivax malaria. But no such abnormality specifically for dengue has been reported yet. Similar abnormalities have also been observed with samples having platelet aggregation, macroplatelets, and nucleated RBCs, which can definitely cause confusion in the reader's mind if this abnormal or abnormality is focused upon. This establishes a definite necessity to identify and differentiate possibility of malaria or dengue infections in patients, especially in endemic areas. Full blood count is most routinely performed blood test for assessment of health status of a person. Endemic areas are largely located in developing countries, which, being extremely cost sensitive, frequently employ low or mid-range analyzer possessing non-laser technology with limited spectral detection capabilities and reagent complexity. Although these affordable technologies generate limited information for detection, data acquired in such a hematology analyzer in a single sample run can still range from 100 to tens of thousands of variables. Pattern recognition per se has been an important integral aspect of survival mechanism in all living organisms. All human beings use this pattern recognition all the time as the learning process to assess the changes in the environment. For that matter, we learn to recognize even the mindset of a person in front of us by facial expressions and body language, which form a specific pattern. So this work hypothesized that this data may yet have the potential for building an automated classifier algorithm with the help of machine learning methods, which is also a process of recognizing patterns by using software algorithm. This is a three-step process which involves learning or training, followed by data analysis, and the last is testing step. So for this flag development by machine learning methods, we too collected around 243 samples in India in 2017 using reference methodologies for the targeted diagnosis. For malaria, it was thin smear, thin peripheral blood smear examination along with auxiliary testing of rapid antigen. For malaria, for Vivax as well as for falciparum. For dengue, NS1 antigen testing by ELISA method was used. All the samples were processed in duplicate on Yumizen H550 for machine learning purpose. Whatever the data was gathered, out of that data, 393 variables were selected with cross-validation, discarding rest of the variables which were having no relevant information for malaria or for dengue. Further data processing, we used two approaches. One was followed by another. First was acquisition of raw data. It lacked information such as cell population data, which requires previous classification. But at the same time, it makes the flags independent from other computations. It also avoids revalidation after a change in calculations in algorithm. This data was further binned. For example, in a histogram, the data is displayed in 128 channels. If every 8 channels represent a single bin, this entire data can be binned into 16 different bins. It increases the robustness as well as it has the better reproducibility which counters instrument to instrument variation as well as reagents batch to batch variability. A prototype software was developed to predict probability scores ranging from 0 to 1. For infection with P. Vivax, it was called ProbPV, and for dengue, it was called ProbDengue in order to ease cutoff tuning. Now comes the last testing step. For any Indian clinical setting, commonest patient presentation is complaint of fever, and accordingly the physician sends a request for basic fever profile, which comprises of full blood count with or without ESR, peripheral blood smear examination for malarial parasite, dengue antigen testing, Vidal testing for typhoid, and urine routine for any infections. Please note that in India, patients have to bear investigation expenses out of their own pocket. So any further testing is decided based on severity of symptoms and socioeconomic status of the patient. So we decided primary patient selection criteria as all the patients visiting the lab for fever profile investigation. As you see in this slide, 1,342 cases visited laboratory for fever profile. The normal, apparently healthy individuals were chosen from cases who had come for or visited laboratory for routine health checkups. All the residual EDTA anticoagulated blood samples were processed in duplicates on HORIBA Analyser, yielding 2,840 runs. For all the samples, diagnostic microscopic blood smear examination for malaria parasite was carried out, specifically for species identification and to assess the parasite density or parasitemia per 2000 RBCs. Further confirmation by rapid antigenic testing for malaria and dengue NS1 antigen with ELISA was carried out. Other demographic data and investigation results, if any, were also collected. This study was taken up in Dr. Dharab's Diagnostic Center, Mumbai, India, between July and October in 2018. Yumizen H550 is a low-range 5-part differential automated analyzer embedding a mini flow cell for WBC counting and differential counting, in addition to RBC platelet channels for counting and volume measurement by impedance, and a hemoglobin channel. As you had seen previously, WBC channel provides a volume by scattering matrix where a cluster of events can be seen mainly with mature forms of P. Vivax. All these cases collected were then further classified as malaria positive cases, dengue positive cases, non-malaria, non-dengue cases, and normal, apparently healthy individuals. As I have told you, auxiliary testing with the help of rapid malarial antigen detection test and recombinase NS1 antigen test were carried out for screening of and diagnosis of dengue fever in all these samples. The table and on the right hand side shows you the number of cases as well as gender distribution and age distribution. First and foremost, we tried to ascertain whether there was any difference, significant difference between the duplicate runs. Mean absolute difference between duplicates on probability scale of 0 to 1 were quite negligible. The receiver operating curve for first and second replicate showed no significant difference for each score. The lower half of this slide represents distribution scores across all groups. It's a box plot diagram which shows the 95 to 95% quantiles spread of all ProbPV and ProbDengue scores with a median and mean of the entire distribution. The groups were healthy control, non-malaria, non-dengue febrile conditions, and specifically Vivax or falciparum malaria for dengue, as well as non-febrile dengue cases. On the left-hand side, it shows the dispersion of ProbPV. On the right-hand side, it shows the dispersion for ProbDengue probability score. This slide shows the performance of Vivax malaria flag. On the left-hand side table, you can see parasitemia or parasite density converted for per 100 RBCs. This group was further classified or grouped as parasitemia less than 0.1% of RBCs. Second group, 0.1 to 1% of RBCs. And third group was parasitemia more than 1% of RBCs. One can clearly make out the differences in the sensitivity across both cutoffs, 0.5 as well as 0.31, which was the optimized cutoff. There is a definite increase in sensitivity across the parasite density or parasitemia percent, and it is an increasing graph. Based on ROC-AUC analysis, this indicates possible linkage to parasitemia levels. The lower half of the table represents sensitivity across the most dominant form found on diagnostic microscopic blood smear examination. And as it shows, the most mature forms give the better sensitivity across both the cutoffs of 0.5 to 0.31. So the detection rate was much better for Schizont, probably as mature forms typically produce more lyse resistance in RBCs and thus give a stronger signal as abnormal infected RBC or IRBC cluster in WBC matrix. On the right hand side, there is an ROC-IUC which displays area under the curve for the three different age groups of children less than 12%, less than 12 years, adults, and elderly individual. As you can see, performance of this particular ProbPV flag was very good when it came to adult as well as elderly individual. It was slightly lower in case of children. This slide shows ProbPV flag score on the left in box plot. On the left hand side, as you can see, the grouping is as per the parasitemia. This box plot shows the higher performance as the parasitemia level increases. On the right hand side is the dispersion of ProbPV score across the dominant forms. This slide shows the performance of dengue fever flag or prob dengue. On the left hand side, one can see two ROC AUC curves. The uppermost shows performance across gender. Some difference in performance associated with gender was found among dengue fever. Similarly, there was differences of performance depending on age, which is represented by the middle ROC AUC curve. For the pediatric group, the lowest specificity was seen. For elderly group, there was a limited number of positive samples, 6, so yielding only 12 runs. The lowermost is a box plot of dispersion of ProbPV flag scores across all three groups in age-wise manner from children to adult to elderly individuals. This slide totally shows the diagnostic performance for Vivax Malaria and Dengue fever flag. We have shown here the sensitivity as well as specificity for the cutoff of 0.5 as well as cutoff of 0.31. There is a definite improvement in sensitivity with optimization of cutoff to 0.31 from 65% to 72% across the groups. The lower half of this screen shows performance of dengue flag. The sensitivity at cutoff 0.5 lingers around 80%, whereas the specificity lingers around 70%. Both the flags show very good negative predictive value. The size of abnormal scatter event clusters was further computed from proportion of cellular events for 1000 WBCs and the total WBC counts, and it was correlated with the microscopic counts of malarial parasite form per 2000 RBCs, which was extrapolated for RBC counts from the analyzer. On examination or analysis, no correlation was found for ring forms or amoeboid forms of Plasmodium with infected RBC counts. However, as it is shown in the left-hand side diagram, there is a strong correlation was found between most mature forms of the Plasmodium, both schizonts and gametocytes, and these infected RBC events in WBC matrix as shown in the right-hand side of this slide. Although the dengue fever flag performance was lower than that for the Vivax malaria flag, it is worthwhile to note that currently there is no reported specific pattern of dengue infection by any standard commercial hematology CBC analyzer. The machine learning process, however, was able to build a model performing a relatively efficient screening indicator for dengue infection. This suggests that the machine learning process has extracted many subtle but parallel variations in cell measures resulting from the unique immune response of patients with dengue fever. This finding further suggests investigative profiling of various other viral diseases might be equally productive. Do understand the limitations of this study as it represents a single site study of an ethnically biased population with a predominance of one malarial species. We also understand that profiling the immune response of the patient might also lead to diagnostic pitfalls or limitations because the response may not be universal and vary from location to location depending on the ethnicity and genetics of patients and or genetic variation of the pathogen itself. So to conclude, for the first time with hematology analyzers using cost-efficient, affordable technology, the HORIBA Medical Yumizen H550 demonstrates flags for Vivax malaria and dengue fever that can be clinically useful for the screening of these infections in low-resource endemic areas and thus facilitate further diagnostic testing in a cost-effective manner. Its ability to screen for diseases like dengue fever without a unique disease-specific signal suggests that machine learning data mining techniques can provide means of disease profiling based upon the immune or cellular response of the patient. This approach continued with continued refinement could be extended to screen for various other pathologies and performance could be further improved as the experiential database increases. This entire study has been published in Malaria Journal recently. The address link has been given below. Please note the address link for further detailed study of this article. HORIBA Medical sponsored the study by providing a test instrument with reagents and paying for additional reference tests on samples. Dr. Parag Dharap, myself a consultant pathologist, was the principal investigator of the study, performed patient inclusion, diagnostics, sample processing, and data collection. Sebastian Reinbold created machine learning flags previous to the study, performed data management and statistical analysis, as well as defined a retrospectively optimized cutoff for Vivax malaria flagging. Sebastian Reinbold is an employee of HORIBA Medical. We didn't stop at 2018 study. I would like to share the data where on-site flag performance was also studied in 2019. In 2018, HORIBA tried to gather more of falciparum infections and hence had set up 2 sites in Africa. In 2019, we could gather in Mumbai, India itself 82 results for malaria falciparum cases. And as you observe on this slide, the sensitivity of 47.6% with specificity of 85.2% was achieved. In 2019, we could gather 248 results of malaria Vivax positivity as well as 234 results for dengue positivity And as you can see, the sensitivity and specificity performance of the flag was as seen in 2018 within the confidence interval given over here. I would like to thank HORIBA Medical for this study, as well as you for patiently listening to the entire presentation.